It's my great honor to attend this session. I will give a topic about image evaluation of patients with aortic regurgitation with TAVR. Above the two lectures, we more focus on the technician, but here I want to show more about the evaluation. So pure AR is the most common valve disease. According to the mechanisms, the AR will be classified into the three types. The one is aortic annulus enlargement, and also the leaflet prolapse or fenestration or the restrict leaflet mutation. So according to the mechanisms, the image assessment is very important to detect AR and the AR severity. Here I list the 5 general points should be addressed. The first is their AR and how severe is AR, and what are the hemodynamic consequences of AR, and is AR associated with aortic dilation or aortic disease, and what's the mechanism AR, and the final question is what's the best the intervention timing. So as we know, the TTE is the most common method to evaluate the AR. So for the AR, we can use TTE to detect the AR or determine the severity. Generally speaking, there are 6 parameters can be used in clinical practice. The first 3 we call the true parameters. It means that we can determine the percentage of the total stroke volume that returns into the ventricular. But the regurgitate volume is more affected by the hemodynamics, and the EROA is more difficult to detect given its very, very smaller size. So the regurgitation fraction, the RF, is more preferred to recommend because of its relative stability, especially when the systolic dysfunction is present. Another 2 meters is about the vena contractor or the jet width relative to LV outflow tact dimension. Also, there is some disadvantage. For example, it will be influenced by the image quantity or the leaflet calcification, and especially will be affected by the jet direction. So another the parameter is diastolic flow reversal. So here is the echo criteria for the definition of severe AR. We can see there is almost the quantitative or the semi-quantitative or the quantitative meters. All of these parameters will help us to define the severe AR. So as we know, in the symptomatic patients with severe VR, and if they met the criteria with the TEE, the aortic valve surgery or the replacement is indicated regardless of the LV systolic function. But in some other conditions, the TEE will also be applied in clinical risk, although it's with some semi-invasive nature, especially in the setting of the primary aortic valve replacement. Here is a procedure I'll show for the TAVR in AR patients. The one is with the vita flow with self-expand valves, and the second is just with yellow valve valves made in China with anchoring rings. But there is still other strategy of TE. First of all, the accurate assessment of the AR mechanisms, and also measurement of the EROA, and especially in the setting of the highly eccentric regurgitate jets. So in the situations, we may see some the discrepancy between the clinical sign and the echo assessment. So how to solve these problems? Here, this is a model maybe help us to definitely to determine the coronary AR assessment based on the dilated left ventricular combined with the traditional 3 echo parameters. The AR could be determined with the severe, the moderate, and the mild. And also this result is very consistent with the MR results. Another important thing is asymptomatic aortic AR. So Although in some of the subgroup populations, maybe we will detect the AR with the echo, but this patient have no obvious clinical signs. So what's the outcomes? So from these registry studies, we found that in the asymptomatic aortic AR, the survival rate will be increased dramatically after the 2 years following up, especially with older people with age more than 50 years old. So based on these poor outcomes, it is recommended that the stress testing is very important on an initial visit in an asymptomatic AR patient to determine the tolerate activities of daily living or establish the baseline levels of exercise capacity. If the patient have the decreased activities, maybe in such a group, the asymptomatic AR maybe have the indication for the future aortic surgery. So how about the stress testing for such kind of the patients? So all of these variables, the echo variables, was got from the registry study, not from the RCT study. So this is a registry study just for the aortic, just for the asymptomatic AR with a long-term observation following up. The patient will divide into with a developed disease and with surgery treatment. Another group has a very stable clinical signs. We see there is a decreased LVEF and also the gradually enlargement of the LV function, as indicated in the LVESV or LVEDV. So until now, all of these parameters we can consider if this parameters is abnormal, maybe the patient has the indication for the future surgery. But we pay more attention about that. We only relied on the cutoff values for parameters that indicate the poor outcomes in medical treated patients. Until now, there is no RCT or studies to detect these parameters, the accurate and the efficiency. So according to the registry study, the ACC guidelines and the ESC guidelines will recommend some indications based on the left ventricular systolic dysfunction or the severe left ventricular dilation or the progressed decline in left ventricular systolic function. So maybe with the development of the RCT studies, maybe all of these guidelines, all the parameters will be altered or changed with the development with RCT study. So how to select the image method? Until now, in the patients with sign or symptomatic AR, TTE is still the first choice to assessment for the cause and severity and also the timing of valve intervention, and especially in the bicuspid aortic valve or the lone aortic dilation, TTE is also the indicator methods. But if the suboptimal TTE image or a discrepancy between the clinical and the TTE findings, the TE and the CMR was another considered another option. So I'll show some study about the additional of the CMR study. So as we know, the CMR has the ability to accurate the AR severity, especially in the presence of aortic dilation. But here it is a very, very interesting phenomenon. For the patient was determined with the echo, was classified to a severe AR. We use a cutoff value is RF is more than 50% and the volume is more than 60 micrometers. But for the MR study, we see only less than one half of the patients could reach these standards. So there is a discrepancy of the cutoff value of the MR and the echo. So when we evaluate the AR patient, we should pay more attention with the different methods. So for the AR severe, for the RF value, the echo cutoff is 50%, but for MR, it's only about 35% with a high specificity and high sensitivity. Also, the same results about the regurgitation volume. So another thing is how to detect the LV function. As we know, LVEF is the most common used indicator for the LV function. The cutoff value is 50%. This is the both in echo and MR detection. But an additional echo markers, the GLS, is abnormal even if the LVEF is normal. And also, these indicators could predict the long-term mortality in AR patients. So for the LV functions, how about the GLs will be used in the detection of AR? Maybe in the future, we can add these parameters to find the early detection of AR of the LV dysfunction. And another thing is the LV dilation and the aortic dilation. So for the AR patients, for the image assessment, we should integrate these 4 points together to determine the right or the best timing intervention or the best instrument or the best surgery methods. So the final thing is the CT. So in this session, we all discuss the patients, the AR patient with the TAVR. So for the TAVR, so which kinds of the methods is the best for this assessment? So the CT is one of the most common used techniques. From the CT scan, we can get information about the annulus, the left ventricular outflow tract, or the STJ, and the ascending aorta. So these results has been published with Dr. Song. He found that crowding the 4 anchoring area, at least the 2 anchoring area, the TAVR maybe can considered and maybe effectively or safely can be used in TAVR for AR patients, but we need more samples and more RCT studies to verify this conclusion. So here is a CNZAR RCT. As I know, this is the first global RCT studies about the AR compared with the TAVR and the medical treatment. And this study is launched by Nanjing First Hospital, and the PI is Dr. Chen and Dr. Zhang. Almost 210 severe AR patients were divided into the TAVR group and the medical group with at least 1 year's following up. We will compare the primary endpoint between these 2 groups. But we should pay more attention about these studies. So what's the criteria for the TAVR group? So in these studies, all of the patients should meet the following criteria based on the CT measure or the TE measurement. So first is the annular parameter should less than 55 micrometers, and also the parameter ratio of the LVOT 4 micrometer to annulus varies from the 1.95 to 1.05. So this is the first RCT study to test this theory and the anchoring area. So we will expect these results in the future. So summary, here I have listed some of the advantage and disadvantage about the image methods. So for SAR severity and its impact on the LV, the best initial method is the TTE, and MR should be applied if the TTE is of poor quality or the data are discordant And the CT has a significant advantage in evaluating the valve and aortic anatomy. I think in the future, we know there is still very questions for the definition and for the assessment. So further clarify the diagnostic and treatment standards through the RCT research are very important for in the future research. Okay, thanks so much.